What are the characteristics of our ischemic stroke? Well, it's important to understand, where did my stroke take place? We call it a cerebral vascular accident, don't we? A CVA. In a cerebral vascular accident, where was the location of this particular stroke? Which blood vessel was it affecting? Was it a large blood vessel? Was it a little blood vessel? What part of the brain was affected? Was it the dominant or non-dominant side? Do you understand that at this juncture, it would be a really good idea for you to have a firm handle of the neuroanatomy, right? Make sure you know where all the important, significant blood vessels are located, what part of the brain that they are supplying, and make sure you understand what that part of the brain, what is it responsible for? What kind of activity? Is it motor or sensory? So on and so forth. Those kind of questions become important for us, and it's important that you understand what part of the brain is responsible for what kind of function. Maximal at onset. Remember that husband of sitting on a recliner chair, watching TV, and all of a sudden, boom, it happened quickly. Slurring of the speech, wasn't able to walk, maybe blurring of the vision. That's characteristic of a stroke. May have a stepwise progression, depending on the etiology. Now, you've heard of multi-infarct dementia, maybe, perhaps. And so, therefore, as you have more and more of your blood vessels that are being blocked and blocked and blocked, and then the dementia that is setting in takes a stepwise, deterioration. Let's talk further about risk factors. Hypertension being one of the most common risk factors for ischemic stroke. And if it is hypertension, then what may then happen to the blood vessel focally? Good. Talk about benign chronic type hypertension, then you know about hyaline arteriolosclerosis. That could be a possible risk factor. What about diabetes itself? Diabetes, most of the time accompanied by hyperlipidemia, resulting in atherosclerosis, stroke. Tobacco with history of stroke or TIA. Now, smoking itself or tobacco is an injurious agent. Heart disease, for example, we talked about atrial fibrillation. Or what if there is valvular disease or cardiomyopathy? Take a look at those conditions, please. All those conditions are the perfect environment to develop a thrombi and then eventually embolize, resulting in a type of focal stroke. Patient has hypercholesterolemia and age. These are common sense type of risk factors, but nonetheless important ones that you want to keep in mind. Genetic conditions. Now, these you may or may not be too familiar with, but I would recommend that you have a pretty good idea as to some of these conditions genetically. There's something called CADASIL, which is your cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. And specifically, there's a gene is called Notch3 gene, CADASIL. So this patient, unfortunately, develops a stroke, and risk factors are not present, but genetically is prone to have one. And that just sucks. Sickle cell disease, hypercoagulable state. For example, cancer is almost always associated with a hypercoagulable state. Pregnancy. Remember, whenever you think about the hormone estrogen, you know your patient is in a state of or at risk for hypercoagulability. Hence, you want to try to avoid oral contraceptive pills that have estrogen. During hormone replacement therapy, you're worried about estrogen. When you have liver disease, you're worried about heightened levels of estrogen. Pregnancy, you're worried about heightened levels of estrogen. Hypercoagulable states. What else? How about antiphospholipid syndrome? Remember this condition. Antiphospholipid syndrome, autoimmune disease. There could be a small percentage of patients that go on to develop SLE. You've heard of when you do this test. Now, this patient, who is most likely a female, she's trying to become pregnant. When she does, she has a history of multiple miscarriages, unfortunately. Has these thrombi formation both on the venous and the arterial side. It's a hypercoagulable state, autoimmune-wise. And you do a particular test, and you check for the coagulation of this pathology. And what does it do in a test tube? Oh, my goodness. It causes anticoagulation. Why? Well, a lot of research on that. But at this point, we call this particular cell a lupus anticoagulant. But the point is, genetic Or in other words, here's an autoimmune disease, which is now putting your patient at risk for a stroke. Protein C deficiency. So think about protein C. Think about protein S. These are little proteins that come from the liver, And it is in the spectrum of coagulation factors. You've heard of your 2, 7, 9, and 10, and those are procoagulant, aren't they? And then you have protein C and S. And protein C and S, if I were you, I would specifically make sure that you have an understanding of protein C and S, which normally breaks down factor 5. Yes, technically also factor 8, but at least no factor 5. The reason I say that to you is because another very important and common, actually the most common, hereditary type of hypercoagulable state is called factor 5 latent disease. Say that your patient has protein C or S deficiency. You can't break down factor 5. Your patient is in a state of hypercoagulable. Are you putting all this together? Don't just look at this list and memorize. Make sure that you know the pathogenesis for many of these conditions that I'm giving you.